movement of stones in the gallbladder. If we talk about the types of gallstones, they can be divided into cholesterol stones and the pigmented stones. In cholesterol stone, we can further classify it as pure cholesterol stone, which comprise only 10% of the total stone count, and mixed stone, which is composed of cholesterol, bile pigment, and calcium. These mixed type of stone comprise 90% of the total cholesterol stones, and the other one are pigment stones, which are made up of calcium salts of bilirubin, phosphate, carbonate, and other anions. There reside some risk factors which contribute in the development of cholesterol stones, which can be summarized as the excessive secretion of cholesterol by liver, which is the most important factor in the stone formation. Increased cholesterol secretion occur in the following conditions, like in females, male to female ratio of gallstone is 1:3. Females are more prone to gallstones. Obesity, exogenous estrogen, and the advancing age, mostly 40 years and onwards, is also a risk factor for the development of gallstones. Diabetes mellitus, which is also associated with the high cholesterol, pregnancy, and rapid weight loss. And when we talk about the risk factor of pigment stones, these include hemolytic anemias like in malaria, ileal disease or resection like Crohn disease, which cause inflammation and ulcer of bowel, and infection of biliary tract and bile stasis. So all these factors contribute in the development of or considered as risk factor. The pathogenesis of the cholesterol stones can be explained as these stones develop when the bile is supersaturated with cholesterol relative to the bile salt. So the cholesterol to bile salt ratio increase and the cholesterol secretion is increased or the bile salts are reduced. This may contribute in the disturbed ratio of cholesterol relative to the bile salts, and decreased amount of the bile salt may be due to the defective synthesis or excessive intestinal loss. As we know, the cholesterol is insoluble in bile salts, and the phospholipids make it soluble in gallbladder, and hence prevents it from precipitating. So, if cholesterol is reduced, precipitation of cholesterol occur. If bile salts reduce, precipitation of cholesterol occurs, which lead to the formation of gallstones. And when we talk about the pathogenesis of pigment stones, so as cholesterol, unconjugated bilirubin is insoluble and precipitates in gallbladder. Conjugation of bilirubin prevents this precipitation. So, if the unconjugated bilirubin level is high, so which usually raised in condition of hemolytic anemias or infection, which ultimately cause the deconjugation of bilirubin via bacterial beta glucuronidase, and the unconjugated bilirubin is prone to precipitation as it is insoluble, so it precipitates and form the pigment stones. In case of gallstone, patient present with the following symptoms, and he or she can be asymptomatic, as about 80% of the cases are asymptomatic in case of gallstones. And if we talk about the symptomatic gallstone, so this condition manifests either as biliary colic or cholecystitis, which is the inflammation of gallbladder, and uh, biliary colic usually occur if the stone is acutely impacted in the cystic duct, the duct which connects the gallbladder to the common hepatic duct. So the pain in this condition is felt in the epigastrium in 70% of cases, or the pain may be felt in right upper quadrant, which which comprise only in 20% of cases, and this pain also radiate to the intrascapular region or tip of the right scapula. If we not take necessity measures to treat or cure the gallstones, it ultimately leads to the complication which maybe acute or chronic cholecystitis, the inflammation of gall bladder, and gallstone may also pass into common bile duct, which gave rise to the biliary obstruction that produce pain in the right upper quadrant with or without obstructive jaundice. So, jaundice is the complication of the gallstones if it got impacted in the common bile duct, and rarely gallstones may perforate through the wall of inflamed gallbladder into the intestine, which produce a fistula, and if stone is large, it impacts in terminal ileum, causing intestinal obstruction. And other complication is the empyema of gallbladder, which is basically due to the bacterial infection. If the bacteria containing bile is present, and uh, secondary infection occurs, and obstruction of the cystic ducts ultimately leads to the slow distension of the gallbladder from continuous secretion of mucus forming, and it will ultimately lead to the formation of mucocele, and hence if this material becomes infected later on, it will cause empyema. We perform following investigation for the confirmation of the diagnosis. Uh, the ultrasound is usually method of choice for diagnosis of the gallstones, as it shows the dilated extra and intrahepatic ducts when common bile duct is obstructed. The other investigation is the ERCP, which is endoscopic retrograde cholangiography. This investigation determines the cause of common bile duct obstruction, and this can be diagnostic or therapeutic. If it is therapeutic, then stones can be removed from the common bile duct during the procedure. And the last investigation is the X-ray abdomen. Plain X-ray abdomen shows gallstone in 10 to 20 cases only. No? So that's why this is not useful investigation for the diagnosis of gallstone. And if we talk about the management of the gallstone, so it depends upon the clinical features of the patient. If the patient is asymptomatic, then there is no need of any treatment. We will go for conservative management, and if the patient is symptomatic and comes with the pain, so we consider some of the treatment options, which include surgery, and in medical term we call it cholecystectomy, and preferably laparoscopic or otherwise open surgery is the treatment of choice for synthetic gallstones. Uh, Usually, this procedure is suitable for most of the patient, including those with acute cholecystitis. And the other way of treatment is the endoscopic sphincterectomy. Common bile duct stones can be removed by the endoscopic technique. And the next management technique is the gallstone dissolution. In this case, the cholesterol stones can be dissolved by bile acid, and which increase the cholesterol solubility in the bile. The only dissolve radiolucent stones, not all type of stones. So only 10% patients are suitable for this therapy due to the specificity of this management. At it only dissolve the radiolucent stones. Um, and only 10% patients are suitable for this therapy because only those patients who refuse surgery. So yes, and this management is suitable only for those patients who come with the functioning gallbladder, and gallstone dissolution takes about 6 months to 2 years, and even after this management, the stones reoccur in 50% of the patient as soon as after the treatment is stopped. And the last management technique is the lithotripsy, which is in which we use shock wave treatment. And this shock wave treatment of gallstones, which is called lithotripsy, can be carried out using ultrasound guided lithotripters for single radiolucent stones. And there is a condition that stones should be less than 20 mm in size in diameter, with advantage of being non-invasive and safe, but usually not recommended. So That was all about the gallstones, its causes, its pathogenesis, its clinical features, investigation, and the management. Thank you so much.